Assalamu alaikum. Should we wait for a few minutes?
I think, Kiran, maximum you can wait for a couple of minutes. I think then we start.
Okay, sure. Sure, Dr. Hassan.
Dr. Bilal Nasir with us.
Yes, sir.
Assalamu alaikum. Assalamu alaikum, Nasir. Thank you very much.
No issues, sir.
I think
Jazakallah.
there'll be, because otherwise it will take a lot of time. Kiran, I think you can start.
Sure. Assalamu alaikum. My name is Kiran Amir and I am the Director Operations at Parsa Echo Pakistan Super Hub. I would like to welcome you all to Echo session in series of digestive disease Echo. It's in collaboration with Rising Foundation and we are thankful to Gets Pharma for the unrestricted educational grant. Today's session is titled Functional Esophageal Disorder and our expert for today's session is Dr. Muhammad Bilal Nasir. Before I introduce to our expert for today's session, we have to go through some standard announcements. We are part of a global movement called Project ECHO based in USA with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation. So you can unmute yourself for questions and use the raised hand option and chat box. By participating, you have given the consent for recording. The recorded session will be available on our YouTube channel. Link will be shared in the chat box. For CME credits, please contact Uzair, our coordinator. His number is mentioned on the banner. CME credits are affiliated with Nasir Medical University. I will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the opportunity of CMEs. For the convenience of the spokes, the session is bilingual. Please speak in Urdu or English, whatever language you are comfortable in. Our expert for today is Dr. Muhammad Bilal Nasir, is one of the top consultant gastroenterologists in Lahore, having the degree of FCPS MBBS. Currently, he is practicing as associate professor and head of department of gastroenterology at Gulab Devi Teaching Hospital, Lahore. He specializes in treatment of PEG tube placement, therapeutic ERCP, diagnostic ERCP, and all other diseases related to his specialty. He is also a member of Pakistan Society of Hepatology since 2013. He has many publications, international and national, in his name. So without further ado, I will hand over to Dr. Bilal. Over to you, Dr. Bilal.
Thank you, Dr. Kiran. I am sharing my screen.
It's visible.
Okay, just a moment. Okay, it's fine.
We can see your slides now, Bilal.
Okay. Thank you.
Yes.
Thank you, Parsa, and thank you, Echo Group, for inviting me to speak on this topic, which is quite common in our day-to-day practice. I mean, I don't think so. At any day, when we see patients in OPD or indoor, we have these symptoms, patients with these symptoms quite often. So functional esophageal disorders, if we define according to the Rome 4 criteria, the presence of esophageal symptoms like heartburn, chest pain, dysphagia, globus that are not explained by mechanical obstruction like stricture, tumor, eosinophilic esophagitis, or major motor disorders like eclesia, outflow obstruction, absent contractility, distal esophageal spasm, or jackhammer esophagus, or reflux disease. And for the definition of all these functional disorder, it has to be there for past 3 months, and the onset of symptoms should be at least 6 months prior to the diagnosis. So generally, when we have a patient with these symptoms, so we need to rule out that whether they have any mechanical obstruction or not, whether they have any major motor disorder or gastroesophageal reflux disease. And these symptoms should be present for at least 3 months. So if the patient is presenting acutely, it won't be classified in functional esophageal disorders. And the esophageal group of Rom 4 define or divided these functional esophageal disorder into 5 subclasses: functional chest pain, functional heartburn, reflux hypersensitivity, globus, and functional dysphagia. So we will be discussing these one by one. Before going into the detail of these 5 disorders, I must discuss briefly about the investigation which we have to perform in these patients which are not responding to our conventional or empirical therapies. So the investigation which we came across during the diagnosis of these disorders are upper GI endoscopy, which we know, the ambulatory pH monitoring with impedance, which can be done with the wireless capsule, or it can be done with the help of the probe which we place into the esophagus, and esophageal manometry. So this is the pictures from the esophagus, like GERD symptoms which we commonly see in patients with heartburn. Uh, this is the basically Bravo capsule, which is there. This is the capsule which we place into the esophagus of the patient 5 centimeter above the LES, and it remains there. This is the recorder with it. It records the pH of the esophageal mucosa during the next 48 hours. Then this dislodges, and then we study that tracing, and we can have evidence that the patient have reflux disease or not. This is the second way, which we place a probe. It is with the wire and it is connected with this monitor. So the patient has remain with this probe and the monitor for 24 hours, and he has to record different symptom of it, and then we classify it. But then we study that tracing, and we will label that whether patient have acid reflux, or patient have symptom association with that low pH. This is the different tracing of that 24-hour pH monitoring. And if the patient have pH of less than 4, and it is the acid exposure time is more than 4% or more than 6%, the mustard score, this is another score to diagnose this. And if patient has more than 70 reflexes on impedance, then we can label this patient as a reflux patient. This is the high resolution manometry. Going through this slide quickly, that this is the upper esophageal sphincter. This is the lower esophageal sphincter. Whenever we have a swallow, we will look at that upper esophageal sphincter is open. There is a gap between these two colors, and then we have the closure of the upper esophageal. Then the wave passes downward till the lower end of the esophagus, and here when we have the opening in the upper esophageal sphincter, at the same time the lower esophageal sphincter get relaxed, and we have this beautiful picture, the normal manometry of a patient. But if we are seeing a patient with reflux disease, then we can have these weak peristalsis, or it can be due to some other causes, the motor causes, like patient can have ineffective peristalsis or no peristalsis without, and we can rule out eclesia on that, DES, and the jackhammer esophagus with these high resolution manometry. So coming back to the main topic, the functional chest pain. The criteria for functional chest pain is that it is a retrosternal chest pain or discomfort absence of associated esophageal symptoms such as heartburn or dysphagia, absence of evidence that gastroesophageal reflux or eosinophilic esophagitis are the causes of symptom, and absence of major esophageal motor disorder. So if patient presented to us with retrosternal chest pain, he don't have an evidence of reflux or eosinophilic esophagitis and any major motor disorder, we can classify this patient as a, a functional chest pain, and we have to rule out the cardiac side as well. The prevalence of non-cardiac chest pain by age and gender. This is a study which is done in 1999, which shows that there is equal gender presentation in patients who have this non-cardiac chest pain, but considering the age, which is 50 to 90 years, 50 to 60 years, when we have more number of females who are presenting to us with non-cardiac chest pain. And when we investigate these patients, so in those patients, 50 to 60% have gastroesophageal reflux, 15 to 80% have esophageal dysmotility, and 32 to 35% have true functional chest pain. So they are classified as functional chest pain. The pathophysiology, and this pathophysiology or this slide is true for all the functional esophageal disorder. Like there is a problem with the sensitization of esophageal nerve, like peripheral sensitization. It is associated with sensitization of the spinal nerves, like sensor sensitization, and there is an important role of psychological modulation, like anxiety, stress. So we have an evidence that patient with these esophageal disorder, like functional chest pain, they do have higher scores on the different psychomotor analysis as compared to the control group. So this is another graph which is showing that these are the different scales which we use for the assessment of psychosocial psychological assessment of the patient, and there is a clearly shown that the control, which is the normal people, they have a strong evidence. Patient with functional chest pain, they have a higher number of like some psychomotor association. So we have to consider that these patients must have some psychomotor issues. So this is the algorithm in which we will be like a patient with the chest pain of suspected esophageal region. We have to take a good history and physical examination. And if the non-esophageal etiology is there, like cardiac issue is there, then we have to evaluate and treat accordingly. If patient have risk of cardiac etiology, then cardiac evaluation should be done. Abnormality identified, we have to go for the ischemic heart disease. If no, then we will give a trial of PPI to these patients. And if the patient is responded to this PPI therapy, then we presume this patient as a gastroesophageal reflux, and we will be titrating this therapy. Next is the upper GI endoscopy with biopsy to rule out eosinophilic esophagitis. If patient had not responding to PPI, then we will be going for upper GI endoscopy with biopsy to rule out eosinophilic esophagitis. And if we find out abnormality, no abnormality, then we'll be moving towards the pH impedance studies. And if on the impedance studies we don't find anything, we will be going for the manometry. And if it is the manometry is also normal, we label this patient as functional surprise. So starting from a chest pain of esophageal origin, we have to go through the upper GI endoscopy with the biopsy. We have to go with the pH monitoring, and then later on we have to go with the manometry of these patients. So regarding the management is again according to the pathophysiology, like we have to target the sensitization, peripheral sensitization by giving gabapentin, amitriptyline, SSRI or SNRIs, or patient need psychological or psychiatric approaches like CBT, hypnotherapy, deep breathing, and SSRI. So these need to be added to the therapy, or sometime isolate independently. We give these treatment, and patient gets better with the in his progress. So this is basically the pharmacological treatment of functional chest pain, in which the different drugs which we have tried, and in those these all are randomized control trial, and they do have side effects with that, but we see that they have more than 50% improvement with these symptoms. The second problem is functional heartburn, in which the criteria is the burning retrosternal discomfort or pain, no symptom relief despite optimal anti-secretory therapy like lack of PPI response, and absence of evidence that gastroesophageal reflux disease is there. We have to rule out eosinophilic esophagitis, absence of major motor disorders, and criteria must fulfill the past 3 months, and symptoms should be there for at least 6 months. So psychological factor in this functional heartburn is several. We have several models of acute experimental stress or auditory stress. Sleep deprivation indicate the stress enhances the perception of esophageal acid in GERD patient. So patient with functional heartburn show, compared with patient with reflux associated symptom, they have greater anxiety, somatization score, and poor social support. Management, again, we have to provide reassurance to these patients. What should be avoided in these patients? It should be avoided with the repetitive invasive testing. Like the patient is labeled as functional heartburn, there is no fun of doing endoscopies repeatedly in these patients. Secondly, escalation of anti-reflux therapy won't be working in these patients. Anti-reflux surgery has no role in functional heartburn. We have to treat hypersensitivity by giving these peripheral sensitizer or these pain modulator drugs. The reflux hypersensitivity, this is previously before Rome 4, it is considered to be a part of reflux disease, but now it is considered as reflux hypersensitivity. The retrosternal symptom, including heartburn and chest pain with normal endoscopy, absence of eosinophilic esophagitis, absence of major esophageal motor disorder, and symptom triggered by reflux event despite normal acid exposure on pH or pH impedance monitoring. The response to anti-screen therapy does not exclude the diagnosis. So sometimes we do have overlap between reflux hypersensitivity and gastroesophageal reflux disease. Epidemiology, 37 to 60% of non-esophageal reflux disease patients have normal ambulatory pH monitoring studies of medication. So this is the reason that they have added this reflux hypersensitivity into a functional group. So justification for new category is that, as I've told you, included the acid hypersensitive for the normal esophageal acid exposure, but positive symptom association in NERD population. So they are considered as reflux hypersensitivity patient. Compared with NERD, patient with acid hypersensitivity responds suboptimally to PPI. So how will you differentiate between reflux hypersensitivity and non-erosive reflux disease? So generally, the patient with reflux hypersensitivity responded does show a good response to these PPI therapy. Patient with RS shows a greater likelihood of esophageal mucosal changes compared with functional. So, I mean, like patient presented to us with heartburn and chest pain. So we have to differentiate with normal endoscopy whether this is NERD, whether this is reflux hypersensitivity, or there is like it is the functional heartburn. So it is described on the biopsy, in which we see the dilated intercellular spaces, basal cell thickness, and papillary elongation in patients with esophageal, this reflux hypersensitivity, as compared to functional heartburn, in which there is no mucosal change. Management, again, reassurance is the treatment and respond to anti-screen may be better than in other functional esophageal disorder. Some patient with acid-sensitive esophagus may respond to standard or double dose PPI. Patient with weakly acid or non-acid reflux triggered symptoms generally are refractory to PPI. Limited evidence suggesting that reflux hypersensitivity patient refractory to PPI can respond to anti-reflux procedures. and treat esophageal hypersensitivity by treating the peripheral sensitization. This is a very good like algorithm for heartburn. If patient presents to you with heartburn in normal endoscopy, and we don't have a proven esophageal reflux, so we do pH monitoring of PPI. So we have to stop the PPI in these patients for at least 2 weeks, and then we perform pH monitoring with impedance. And if we see that normal acid exposure, negative symptom reflux association, so this is functional heart. If patient have normal acid exposure but have positive symptom reflux, we consider this group as a reflux hypersensitivity. And if patient have abnormal acid exposure, we consider these patient as non-erosive reflux disease. And similarly, if patient have proven GERD on PPI, we perform pH impedance study on PPI. If patient have normal acid exposure, it is negative symptom reflux association. The patient is considered to be having functional heartburn. And if have normal acid exposure but have positive symptom, we consider that reflux hypersensitivity. And abnormal acid exposure, this is GERD. Functional globus, this is again a common feature which patient presents to us with sensation of lump or foreign body in the throat with no structural lesion identified on physical examination or endoscopy. Occurrence of sensation between meals. So it is usually associated that patients say it doesn't have any association with the meal. Patient always say that there is something sticking in the chest or in the throat. Absence of dysphagia or dinophagia. Absence of evidence that gastroesophageal reflux is the cause of symptom. Absence of gastric inlet patch in the chromosomal sphere. This is one of the things which we need to rule out. Absence of major primary esophageal disorder abnormality. So generally, this gastric inlet patch, which we need to rule out in these patients. So common symptom reported to up to 46% apparently healthy individual, peak onset in middle age, prevalent equally in both sexes. Women are more likely to seek health care. The condition is durable. Symptom typically persist more than 3 years in 75% of the patient, and 50% have persistent symptoms after 7 years. So this gastric inlet patch in the global symptom generation, so we need to rule out these things. Concerted effort to support endoscopic evaluation of the oropharynx, similar to the other functional disorders, separating out major motor disorder not encountered in the health form of the borderline motor disorder found in the asymptomatic control. Pathophysiology of the globus, again, abnormal visceral hypersensitivity and central processing of the peripheral stimuli. No anatomic abnormality is there. The upper esophageal sphincter mechanics do not seem relevant. Pharyngeal swallow mechanism is normal. Esophageal hypersensitivity or esophageal balloon distension sometimes give the symptom of this globus sensation. Treatment, again, mainstay of the treatment is explanation and reassurance. Sorry. And we have to symptom persist in up to 75 patients at 3 years. Controlled trial of antidepressant and behavior therapy of globus are unavailable, but there is anecdotal evidence of their utility. So again, the psychosocial and reassurance is the mainstay of the treatment. If patient have non-painful lump in the throat, history and clinical examination suggest alternative diagnosis. So we'll be evaluating and treating those. If esophageal alarm symptoms are there, we will be going for the upper GI endoscopy. No alarm symptoms are there, we'll be going for the ENT evaluation and laryngoscopy in these patients. And if the abnormality identified, treat as indicated. If patient have the ENT evaluation is again normal, we'll be giving these patients a PPI trial. And if patient doesn't respond to PPI trial, we'll be going for the manometry. And if the manometry shows manometry is normal, we will be then going for the pH and impedance study in these patients. Normal in pH impedance, the patient is labeled as functional globus patient. The functional dysphagia, sense of solid or liquid food sticking, lodging, or passing abnormally through the esophagus, no structural abnormality, absence of GERD or eosinophilic esophagitis, absence of major esophageal disorder, and the same with all other functional disorder, that the symptoms should be at least 3 months and the onset of symptoms should be at least 6 months apart. Epidemiology of these functional dysphagia, 7 to 8% of dysphagia was unaccounted for by exclusionary criteria. Validation study of Rome 2 criteria estimated 0.6% of functional gastroesophageal disease patient complained of frequent dysphagia. So functional dysphagia is deemed to be the least prevalent of functional esophageal disorder. Abnormal esophageal sensory perception, a feeling of food sticking can be induced with balloon distension or the acidification of the esophagus. Both can induce peristaltic dysfunction. So patient can have feeling of dysphagia. To ensure exclusion of subtle mucosal or structural process, including those encountered in GERD and eosinophilic esophagitis, dysphagia can occur even without overt structural lesion in eosinophilic esophagitis. So patients who have functional dysphagia need to have esophageal biopsy on endoscopy to rule out the microscopic cause. And we need to go for the manometry in these patients to look for any major motor disorders. Again, the cause, the pathophysiology, as I have already told you, that the same with the abnormal sensory perception. Minor peristaltic disorder may represent epiphenomena associated with abnormal sensitivity to the distending stimulus. Both peristaltic dysfunction and abnormal visceral sensitivity are potential contributory mechanisms. And the treatment may regress over time. Aggressive management may not be necessary. Again, reassurance is the mainstay of the treatment. Simple non-pharmacological measures like eating in the upright position, avoiding the precipitating food, and careful chewing of the food and chasing food with the liquid may suffice in mild cases. A short trial of PPI dysphagia can be part of reflux spectrum. Antidepressant, particularly tricyclic can be tried. Efficacy is again unknown. And there is a good response to empiric vagal dilatation reported to benefit around 68 to 85% of these patients, but efficacy is the long-term efficacy is not proven yet. So if patient is presented to you with functional dysphagia or dysphagic symptom, we'll be going for history and physical suggest oropharyngeal dysphagia. We have to evaluate and treat. If no, then upper GI endoscopy with the biopsy to rule out eosinophilic esophagitis. If no abnormality found and the reflux symptoms are there, we'll be giving PPI trial. And if patient is not responding to PPI, we'll be going with the manometry to look for any major motor disorder. If the abnormality identified, no abnormality identified, then we label this patient as functional dysphagia. Take-home message is that always take detailed history and clinical examination if patient is not responding to empirical therapy. Urgent referral if alarm symptoms are there or patient is not responding to initial or empirical therapy. And we have to reassurance psychosocial support required for better outcome in all of these functional GI disorders. You can have any question, you are more than welcome.
Thank you. Thank you very much, Bilal. Wonderful presentation. और ये काफी कॉमन टॉपिक्स हैं और हम इसको रोजाना देखते हैं. आप स्टॉप शेयर कर सकते हैं, इफ यू कैन स्टॉप शेयर द स्क्रीन तो वी कैन. तो काफी कॉमनली हम इसको देखते हैं एंड आपने बड़े अच्छे तरीके से मेरा सिर्फ ये क्वेश्चन है कि प्रैक्टिस में आप तो जो कि लाहौर में हैं और प्रैक्टिस में आप कितने लोगों को ये मोटिलिटी स्टडीज की तरफ लेके जाते हैं, क्योंकि अल्टीमेटली तो हमने जो जनरल प्रैक्टिस में मोस्टली जो हमें ज्वाइन कर रहे हैं देर ऑल इन जनरल प्रैक्टिस, तो क्लिनिकल किन पैरामीटर पे आप रिलाय करके और किन पर आप फर्दर इन्वेस्टिगेशंस के लिए जाते हैं, जस्ट फॉर द सेक ऑफ नॉलेज टू एवरीबॉडी?
सर जनरली क्योंकि जो esophageal manometry और 24 hour pH monitoring है, naturally it's not commonly or readily available. Not all the centers are doing these studies. So what we do generally, जो हम patients जब इस तरह के देते हैं तो usually हम उन्हीं patients को ये test advise करते हैं in which the patient is not responding to initial therapy. And generally these patients are quite apprehensive कि मैं दवाई भी खा रहा हूँ और ठीक नहीं हो रहा, डॉक्टर साहब आपने मेरे टेस्ट भी कर लिए और फिर भी मैं ठीक नहीं हो रहा. तो generally what I have seen in these patients, that patients are referring to me for esophageal manometry or these reflux studies. A good number of patients have normal 24-hour pH monitoring and esophageal manometry, and they underwent reflux surgeries for that heartburn or symptoms, and they end up with the problems. So आपकी बात बिल्कुल ठीक है कि हर पेशेंट को कन्विंस करना या हर पेशेंट के लिए ये चीज रखना मुश्किल होता है, बट कंसिडरिंग के आपने इफ यू हैव टू गिव अ डायग्नोसिस टू दीज पेशेंट एंड साइकोसोशल सपोर्ट एंड एंटी डिप्रेसेंट, सो जनरली पेशेंट्स को जब हम एंटी डिप्रेसेंट भी स्टार्ट करते हैं विद द हार्ट बर्न, सो दे ऑलवेज काउंटर चेक इट एंड बाउंस बैक टू यू कि जी मुझे तो डिप्रेशन नहीं है, व्हाई यू आर गिविंग मी दिस. So with these tests, we do have a diagnosis and we can reassure them that देखें आपका प्रॉब्लम एसिड रिफ्लक्स नहीं है, आपका प्रॉब्लम हाइपरसेंसिटिविटी, आपका प्रॉब्लम एसिड रिफ्लक्स या मोटिलिटी डिसऑर्डर नहीं है, आपका प्रॉब्लम sensitization of the mucosa. So we have to we have to shift the treatment from PPI to the other regimen. So, sir, there are good number of patients are coming to me with the with these symptoms, and they are very they responded very well when I give them a reassurance that they don't have evidence based no association of acid exposure in the esophagus. So generally they do very well when we started them on these neuromodulators. If without evidence we start them, so they get confused that I don't have a depression, why you are giving me these tricycle antidepressant or these neuromodulators.
Thank you. Any other question अगर किसी का है, आपके पास रेज हैंड की ऑप्शन है और चैट में भी क्वेश्चन लिख सकते हैं. अच्छा, एक और जो चीज हमारा हाँ बहुत ज्यादा है वो पीपीआई का यूज है, और मैं सिर्फ क्लिनिकली फॉर द सेक ऑफ डिस्कशन, क्योंकि इनवेरिएबली हमारे पास जितने भी मरीज आते हैं वो सब के सब पीपीआई पे होते हैं, और आपके मैं जरा इस पे कोई आई वुड जस्ट लाइक टू हैव योर थॉट्स ऑन दिस कि आप इसको कैसे देखते हैं, क्योंकि ये बहुत बड़ा इशू है, और आई वुड से कि इनडिस्क्रिमिनेटली पीपीआई जो है वो यूज किया जाता है, और अब तो मेडिकल स्टोर अगर डॉक्टर नहीं भी दे रहा तो मेडिकल स्टोर से वो पीपीआई ले रहा है, तो आप इससे कितना को ट्रबल्ड फील करते हैं, स्पेशली इस किस्म की डिस्कशन पे जैसा फंक्शनल हमने डिसऑर्डर्स को डिस्कस किया है.
हाँ सर, बात वही है कि मैं जैसे पहले आपको बता रहा था कि जनरली जब पेशेंट हमारे पास रेफर होता है तो ऑलवेज दे आर ऑन पीपीआई जनरली. अब मोस्टली इवन मैं तो ये देखता हूँ कि अब तो ईएनटी वाले इतना पीपीआई लिखते हैं जितना शायद हमारे गैस्ट्रोएंटरोलॉजिस्ट भी नहीं लिखते फॉर एलपीआर. And when I do the PA studies in those patients, they don't have an evidence of LPR. So generally, the over judicious use of these PPI, they are creating issues. in the diagnosis as well as the long-term effect. And if patient is not responding to PPI, think of something else. Like it's necessary to rule out the other causes. Like patient have eosinophilic esophagitis and we are keeping on giving them a standard dose of PPI and he's not responding. We keep on giving, we're changing the brands. So these are the things which need to be addressed. And I think with these forums, we can tell our colleagues that the PPI are not indicated in all patients. And sometime without PPI, we can treat these patients with reflux hypersensitivity or functional heartburn or functional chest pain.
और ये जो अभी आपने जिक्र किया एक अपार्ट फ्रॉम ये जो ड्रग्स हैं SSRI और SNRI, इनके अलावा जो कॉग्निटिव बिहेवियर थेरापी और ये चीजें हैं, ये पाकिस्तान में आप लोग यूज करते हैं? क्योंकि मेरे इल्म में तो कोई ऐसा नहीं है कि बड़ा अच्छा सिस्टम हो टू हेल्प आउट दिस पेशेंट, स्पेशली ग्लोबस के पेशेंट्स जो हैं, वी हैव सीन देम। आपने भी बताया काफी देर तक ये सिम्टम रहते हैं और रियली पेशेंट रियली बिकम्स एक क्रॉनिक पेशेंट जो बार बार आ रहा है। आपकी प्राइवेट प्रैक्टिस में तो उसको कॉस्ट भी काफी पड़ती है एंड सिम्टम्स आर नॉट इम्प्रूविंग। तो व्हाट डू यू से ऑन दैट?
यस सर, यू आर राइट। जनरली जहाँ पे अब जनरली मेरे पास जो जहाँ पे मैं अपना क्लिनिकली देखता हूँ पेशेंट्स, तो जनरली आई हैव अ साइकोलॉजिस्ट विद मी, I have a psychiatrist as well with me, and generally क्योंकि मेरे mostly जो functional जितने भी GI disorders हैं, खास तौर पे जो patients हैं anorectal dysfunctions के साथ, so वो हमारा एक पूरा group है जो कि इसमें patient को help out करता है, including a physiotherapist as well. So I am not sharing those data, but we are studying even with these functional patients who have some exercises, some diaphragmatic exercises with the physiotherapist. My physiotherapist is doing like working on that project, that they are studying different diaphragmatic exercises and response to patients who have functional heartburn or reflux hypersensitivity. So they are seeing good result in those patients. So I think we need to include these specialties with us to better management of these functional GI disorders, because all have some sort of psychosocial, psychomotor, or even means most of them needs reassurance and time. So they are patients who need more time, and if we divide their time between me, my psychologist, my psychiatrist, or physiotherapist, so they have a very good reassurance that my symptoms are taken care of, and they respond very well to those.
मेरे ख्याल में आपने इतना अच्छा पढ़ाया है कि काफी कुछ टॉपिक था ये।
नहीं, वो बिल्कुल ऐसे ही है सर कि जनरली क्योंकि मैं जब ये इस बात पे काफी सारी क्वेश्चनिंग होती है, जब मैं इस तरह के पेशेंट्स भी देखता हूँ ना, तो वो लोग यही कहते हैं कि तुमने क्या ये एक किस तरह का टॉपिक है जिसको आप कैसे, तो जनरली मीन दीज आर वेरी कॉमन एंड जनरली पीपल थिंक कि जी ये हम इस तरह कर लेंगे तो पेशेंट तो ट्रीट हो ही जाएगा। बट मैंने ये देखा है कि आप वो पेशेंट पहले से पीपीआई ले रहा होगा, एंड व्हेन यू रीअश्योर देम, you give a diagnosis and you start with a low dose PPI and they responded very well. So means this is the thing which is there. और you're right कि थोड़ा सा बोरिंग है, बट लेकिन अगर ये भी ट्रू है कि अगर ये सिम्टम्स खत्म हो जाएं तो जीआई भी खत्म हो जाएगी।
मुझे एक बात बताएं, क्योंकि हम अक्सर लिवर में भी ये बात करते हैं, जो आपसे और आई एम श्योर बहुत सारे डॉक्टर्स हैं जो सीखना चाहेंगे, हाउ टू एक्चुअली काउंसल दीज पेशेंट्स। अब मेरे पास, मैं आपको अपनी मिसाल देता हूँ, बहुत सारे पेशेंट आते हैं 2-2 साल 3-3 साल से, इतने नुस्खे आपको पता ही है, 3-3 दफा एंडोस्कोपी हो चुकी, खैर मैनोमीट्री और ये टेस्ट तो कम होते हैं। तो मैं उनको फिर एक बात जरूर कहता हूँ, मैं कहता हूँ देखो तुम्हें 4 साल हो गए हैं, तो इसमें एक अच्छी बात भी है और बुरी बात भी है। तो अच्छी बात जो अच्छी बात तो ये है कि तुम जिंदा हो, चल रहे हो। और अगर 4 साल में तुम्हें वाकई कोई तुम्हारी खाने की नाली बंद होती तो तुम यहाँ पे 4 महीने बाद मौजूद ही ना होते। बुरी बात यह है कि तुम तंग हो रहे हो। तो इट्स मोर ऑफ अ न्यूसेंस फैक्टर विच यू हैव टू टेक केयर ऑफ, क्योंकि उनकी कंप्लेंट्स तो खत्म ही नहीं होनी। ठीक है। और कुछ पाकिस्तान का मरीज इतनी जल्दी में होता है कि अक्सर ये SSRI SNRI वगैरह दे टेक अ फ्यू वीक्स टू टेक इफेक्ट। अगर 6 हफ्ते लगने हैं, 6 हफ्तों में वो 6 डॉक्टर बदल चुका होता है और हर बंदा उसको एक डिफरेंट दवाई पे शुरू करता है। और ये एक बिल्कुल टुल्ला होता है, जिस तरह वो हमारे बैट्समैन ने अफगानिस्तान में छिका लगाया था कि लग गया तो लग गया। तो वो एक बंदा होता है जो जिसके साथ ना वो हिट हो जाता है, उसके बाद कहता है जी मैं ठीक हो गया हूँ। आप क्या कहेंगे इसके बारे में?
तो आपकी बात सर बिल्कुल ठीक है। एक्चुअली मैंने जैसे पहले भी बताया ना सर कि ये पेशेंट्स इतना घूमा होता है। I mean, they have ton of files कि जी मैंने ये भी ले लिया, मैंने ये भी। Sometimes they are guiding you कि डॉक्टर साहब वो तो नहीं लिख दी, मैंने तो ये खाई हुई है, और ये भी तो नहीं लिख दी। So you are like stuck कि जी मैं तो ये लिखूंगा। सो जनरली जब इस तरह के पेशेंट्स हो तो सर मैंने वैसे अपने उसमें ये देखा है कि जितना हम इनको एविडेंस बेस्ड रीअश्योरेंस देते हैं, they responded very well to that because they are worried that they have. And secondly, we have to tell them that sometime when we say कि तुम्हें कुछ नहीं है, so patient इधर से इग्नोर्ड होता है कि मैं तो बीमार हूँ, ये मुझे कहते हैं कुछ नहीं है। So reassurance means like we have to tell them that you have a problem but it's not a serious one. You have a problem, we can understand that you are suffering from these symptoms, but this is not a symptom which can complicate into some other symptom. And we have done these investigations, we have to rule out everything. Now we have to give you these medication and we have to wait and it will get settled. So sir multiple therapies हैं which I do agree कि ये बड़े मुश्किल होते हैं patients convince करना, इनको टाइम और ट्रीटमेंट देना ही एक बहुत बड़ा मुश्किल काम है, क्योंकि ये जनरली जैसे बाउंस करते हैं एक क्लिनिक से दूसरे क्लिनिक, दूसरे से तीसरे क्लिनिक। सो रीअश्योरेंस अगेन वही है कि कितना आपने इनको टाइम दिया और कितना रीअश्योर किया। सो दे रिस्पोंडेड वेरी वेल टू दीस थिंग्स।
Thank you, Bilal. I think if there are no further questions, so we can follow. Before I hand it over to Kiran, Bilal, thank you very much for being with us, and to all the audience. I think ये तो functional GI disorders हैं, अभी हमने upper को cover किया है, अभी इसके 2-3 segments और हैं। Irritable bowel syndrome पूरे का पूरा हमारा पड़ा हुआ है, तो we are going to cover it up. In this monthly session with support from Gets Pharma will continue. One last thing is I also represent Pakistan Society of Hepatology, and Pakistan Society of Hepatology and Parsa Echo go hand in hand, and we are partners for the past 2 to 3 years now for this full-blown hepatitis and liver disease echo. So our international meeting, Pakistan Society of Hepatology Annual Congress, is due 23rd, 24th and 25th of September. That will be week next Friday, and it will be in Lahore per Continental. So all of you are welcome. Please join us there. And we keep moving forward on the taking education forward, taking the treatment to the people. Kiran, over to you.
Thank you very much, Dr. Asad. जैसे डॉक्टर असद ने जिक्र किया, PSH और पारसा एको पाकिस्तान की कोलैबोरेशंस है काफ़ी सालों से, और इस दफ़ा हमारी प्रेजेंस एज अ स्टॉल उधर होगी। और इसके इफ़ यू आर इंटरेस्टेड इन बिकमिंग अ हब, तो वी एज अ सुपर हब कैन टेक यू अहेड। और इसके लिए हमारे पास डिफरेंट किस्म का मटेरियल, और आपके लिए किसी किस्म की कोई नॉलेज आपने इसके बारे में लेनी है तो वी विल बी देयर। और थैंक यू डॉक्टर बिलाल फॉर एन एक्सेलेंट सेशन। और इसके अलावा वी डू इनकरेज केसेस फ्रॉम द पार्टिसिपेंट्स। अगर आपके पास कोई केस है और आप प्रेजेंट करना चाहते हैं तो यू कैन contact us, तो हम आपको एक relevant format फराहम कर सकते हैं upcoming sessions के लिए अगर आपने कोई case present करना हो. And we are grateful and thankful to all the participants, especially Dr. Bilal as an expert, or Gets Pharma for the unrestricted educational grant. Special thanks to Khalid Mahmood Saab and of course our team at Parsa Eco Pakistan. And we hope that this collaboration with the Isaac Foundation will produce more informative sessions in future for you. We will sign off for today.